Ever wondered what truly goes on inside your gut? And maybe more importantly, how doctors choose the right medications when things go, well, awry. It's far more complex and fascinating than just reaching for an antacid. Welcome to the deep dive.
That's exactly right. Today, we're embarking on a really comprehensive deep dive into the intricate pharmacology of gastrointestinal diseases.
Yeah.
We've meticulously curated a wealth of information to guide you through the latest treatments, the sophisticated science behind how they work, and what makes them the go-to choices for a whole array of conditions.
Our mission today is to give you a shortcut to a truly professional level understanding. We're going to break down some, pretty dense science into surprising facts and genuine aha moments. The goal, so you can truly master this information, like the elite professionals in this field. Think of us as your personal guides through the inner workings of GI medicine, making sure you grasp every concept, every mechanism in detail.
Yeah, we'll explore everything from common heartburn remedies all the way to highly specialized treatments for chronic inflammatory conditions. We'll dissect the mechanisms, dig into their clinical uses, and definitely highlight crucial side effects of each. By the end of this deep dive, you'll understand not just what drugs are used, but why they matter and how they fit into the bigger picture of patient care. Okay, let's unpack this.
So, where do we begin our journey into GI pharmacology? Let's start with acid-peptic diseases, a remarkably common group of conditions. They affect millions.
Right. These include things like gastroesophageal reflux disease, you probably know it as GER, peptic ulcer disease, which covers both gastric and duodenal ulcers, and also stress-related mucosal injury. At its core, what's happening here is a critical imbalance. Basically, the aggressive factors within the gut are just overwhelming its natural defenses.
An imbalance, okay.
Exactly. And this imbalance leads to damaging erosions or even deeper ulcerations in the lining. It's like a constant battle inside the gut, a delicate equilibrium that can easily get thrown off.
And what exactly are these aggressive factors causing all the trouble? We're talking about stomach acid itself, obviously, which is incredibly potent. It's designed to break down food, after all. Then there's pepsin, an enzyme that works with acid to digest proteins. But the culprits also include things from the outside, like non-steroidal anti-inflammatory drugs, NSAIDs. They can directly irritate the stomach lining.
Yeah, NSAIDs are a big one.
And, crucially, the bacterium Helicobacter pylori. Plus, even bile, which normally stays in the small intestine, can sometimes reflux back into the stomach and esophagus, adding to that corrosive mix.
Right. But on the flip side, the body has these absolutely critical defensive factors, its own built-in shields. These include things like robust mucus secretion, right? A thick protective layer coating the stomach lining, and bicarbonate secretion, which acts as a buffer, creating a neutral pH right at the surface.
Like a little safe zone.
Exactly. Prostaglandins also play a vital protective role. They stimulate mucus and bicarbonate, ensure good blood flow for nutrients and repair. And finally, the mucosa itself has this remarkable ability to repair itself after injury through processes called restitution and regeneration. It's really a marvel of biological engineering, always trying to maintain that balance.
So looking specifically at GERD, the main issue isn't always too much acid, right? It's more about the reflux of normal stomach contents, acid and pepsin flowing backward, refluxing, up into the esophagus. That causes the classic heartburn and can damage the lining over time.
And here's where it gets really interesting and just crucial for understanding treatment. When we look at peptic ulcers, over 90% of them boil down to two main culprits. It's either an infection with Helicobacter pylori, that stubborn bacterium we mentioned, or it's the prolonged use of NSAIDs. Understanding these specific root causes directly shapes how we approach treatment. Because if you don't tackle the underlying cause, whether it's the bug or the drug, you're fighting an uphill battle. The ulcer will probably just come back.
Right. So the drugs used in these acid-peptic disorders basically fall into two big buckets, representing different strategies. First, you've got the ones that directly reduce the acidity in the stomach.
Yep, turn down the acid.
And second, those that work to promote and strengthen the gut's own mucosal defenses, kind of giving its natural shields an extra boost. We're going to dive deep into each of these now.
Okay, so to really get how these acid-reducing drugs work, we need a quick but crucial look at how your stomach actually makes acid. The key player here is a highly specialized cell called the parietal cell. It's mostly found in the fundus, that's the upper dome-shaped part of the stomach. Think of it as the stomach's little acid factory.
And these parietal cells aren't just, blindly pumping out acid. They're like sophisticated command centers with specific docking stations or receptors for different chemical signals. There are receptors for gastrin, called CCKB, for histamine, the H2 receptor, and for acetylcholine, which are muscarinic M3 type receptors.
Hmm.
So when messengers like acetylcholine from vagal nerves or gastrin from G cells in the stomach's antrum bind to these receptors, they trigger an increase in calcium inside the cell. This calcium surge then activates a whole cascade that ultimately stimulates the H plus K plus 8T pace, that's the famous proton pump, right on the cell surface.
Right, the pump itself.
Exactly. And this pump then actively pushes acid, hydrochloric acid, into the stomach lumen. It's a really finely tuned, highly regulated system. Precision is key.
And what's fascinating here is the crucial sort of indirect role of another cell type, the enterochromaffin-like cell, or ECL cell.
Yeah.
These guys sit really close to the parietal cells and also have receptors for gastrin and acetylcholine.
Yeah.
So when they get stimulated, the ECL cells act like intermediaries. They release histamine. This histamine then travels just a tiny distance to bind specifically to that H2 receptor on the parietal cell.
Yeah.
This binding activates a different pathway inside the parietal cell, but it also stimulates acid secretion via that very same proton pump.
So multiple signals lead to the same pump?
Exactly. You have this complex cascade where different signals, direct or indirect, ultimately converge on that one proton pump. It's the final common pathway for making acid.
And it's important to understand the hierarchy in humans, right? Gastrin's major effect seems to be indirect, mostly by getting those ECL cells to release histamine.
That's the current thinking, yes. Primarily indirect through histamine.
Whereas acetylcholine provides a potent direct kick to the parietal cells themselves. Different pathways, but all roads lead to the proton pump.
Right. And as powerful as acid secretion is, it has to be turned off eventually. This control involves antral D cells, which release somatostatin. Somatostatin release gets triggered when the acidity level in the stomach gets too high, basically. Too much H plus concentration, and also by CCK, which is released from duodenal eye cells when food moves into the small intestine.
A feedback loop.
Precisely. Somatostatin then acts as that crucial shutoff switch by inhibiting further gastrin release from the G cells. It completes a vital negative feedback loop. So this naturally raises the question. Knowing all these intricate pathways, how exactly do our drugs strategically manipulate these complex signals to fix things and restore balance?
Okay, let's start with the basics. Antacids. They've been around forever, centuries really, long before modern pharmacology. They were the original go-to for indigestion, acid-peptic issues. Even now, you see them everywhere as common, non-prescription remedies for occasional heartburn. Tried and true, maybe a bit old school, but they still have a place.
Mm-hmm. Their mechanism is incredibly straightforward, almost elegantly simple, really. They are just weak bases that react directly with the hydrochloric acid in your stomach. They form a salt and water, their main job. Reduce intragastric acidity fast.
Like pouring baking soda on vinegar.
Exactly like that. A direct chemical neutralization.
And their capacity to neutralize that varies quite a bit, doesn't it? Like a single dose of, say, 156 millieq of antacid taken an hour after a meal can neutralize stomach acid for maybe up to 2 hours, considering your stomach turns out about 45 millieq of acid per hour.
Right.
But here's a key thing for professionals to grasp. The actual acid neutralization capacity varies wildly between different brands and formulations. It's not just the active ingredient amount. It depends on things like dissolution rate. Is it a fast liquid or a slow tablet? Solubility, how fast it reacts, even how quickly your stomach empties. So not all antacids are created equal, right?
Absolutely not. And let's break down the specific types and their side effects, because they really do differ. First, sodium bicarbonate. Think baking soda, Alka-Seltzer, reacts super fast, gives quick relief, but it produces carbon dioxide.
The belching.
Exactly. Gastric distension, belching. More seriously, any unabsorbed alkali can cause metabolic alkalosis, especially in high doses or with kidney problems. Plus, the sodium chloride absorption can worsen fluid retention. Big concern for patients with heart failure, hypertension, or renal issues.
Okay. What about calcium carbonate, like Tums?
Right. Calcium carbonate, Tums, Oscal. Less soluble, reacts slower. It also forms carbon dioxide, so still expect belching, potential metabolic alkalosis.
Right.
A crucial thing here is excessive doses, especially with lots of dairy, can lead to milk alkali syndrome. That's serious high blood calcium, kidney problems, metabolic alkalosis.
Wow, okay.
Finally, magnesium hydroxide and aluminum hydroxide, often combined like in Jolzol, Melox, Melanta. They react slower, no gas generated, so no belching. metabolic alkalosis is uncommon. What's really neat and practical is their opposing bowel effects. Magnesium salts cause osmotic diarrhea,
Right, milk of magnesia.
while aluminum salts cause constipation. That's precisely why they're often combined to balance things out, keep things regular. Both are absorbed a bit and need kidney excretion, so long-term use requires caution in renal insufficiency, risk of buildup.
Here's a crucial takeaway, a real must-know for any professional using or recommending these. All antacids can mess with the absorption of other medications. They do it either by directly binding to the drug, physically stopping it from being absorbed, or by changing the stomach pH, which can mess up how other drugs dissolve or become soluble, especially those needing a specific pH. This is why you absolutely should avoid taking antacids within 2 hours of drugs like tetracyclines, fluoroquinolones, itraconazole, and iron. Simple rule, big impact on other meds working properly.
Okay, moving on from antacids, let's look at H2 antagonists, or H2 blockers. From the 70s to the early 90s, these were huge. Among the most prescribed drugs globally, their use, though, has dropped significantly.
Why the decline?
Two main reasons. First, a much better understanding of H. pylori's role in ulcers. Now we can target that directly with antibiotics. And second, the arrival of proton-pump inhibitors, PPIs, which are just much stronger acid suppressors.
Right, so which H2 blockers are still around?
3 are currently in clinical use: cimetidine, famotidine, and nizatidine. You might remember ranitidine Zantac. It was incredibly common. But it was pulled from the market due to concerns about a probable carcinogen contaminant, NDMA, especially when stored at higher temperatures. A real issue with drug stability.
Ah, okay. So how do these work in the body? Pharmacokinetics.
Right, the body's journey. All 3 are absorbed pretty quickly. Cimetidine and famotidine have about 50% bioavailability because they go through significant first-pass metabolism in the liver. Nizatidine, much less so. Their serum half-lives are short, like 1 to 4 hours, but the duration of action depends on the dose, lasting maybe 6 to 10 hours for OTC doses, longer for prescription strengths.
And how are they cleared?
Cleared by both the liver and kidneys. So dose reduction is definitely needed for moderate to severe renal problems, possibly severe liver issues too, especially important in the elderly, where clearance naturally declines quite a bit. You need careful dose adjustments there.
Okay, and how do they actually work, the pharmacodynamics?
They act as competitive inhibitors at the parietal cell H2 receptor. Think of it like musical chairs. The H2 blocker grabs the chair histamine wants, so histamine can't bind. This suppresses both basal acid between meals and meal-stimulated acid in a dose-dependent way. They're highly selective for H2 receptors, don't hit other histamine receptors much. They also reduce the total volume of gastric secretion and pepsin concentration.
So they block histamine.
Right, but what's interesting is their dual mechanism. They reduce acid stimulated not just by histamine, but also by gastrin and acetylcholine. How? 1, they directly block histamine release from ECL cells from binding to the parietal H2 receptor. 2, by blocking that H2 receptor, they also lessen the impact of direct gastrin or acetylcholine stimulation on the parietal cells, even though they don't block those signals directly. It's like turning down the volume on multiple inputs, feeding that acid pump.
Interesting. How effective are they overall?
Well, their potencies vary a lot. Famotidine is way more potent than cimetidine, like 20, 50 times. But in usual prescription doses, they all inhibit about 60–70% of total 24-hour acid secretion. They are especially good at inhibiting nighttime acid secretion, which relies heavily on histamine.
Oh, okay.
But they have a more modest impact on meal-stimulated acid because that also involves gastrin and acetylcholine directly. So they raise nighttime pH nicely, maybe to 4 or 5, but have less impact during the day. It's exactly why they're often given twice daily to keep that suppression going, especially overnight.
Makes sense. Where do they fit in clinically now?
Good question. For GERD, like infrequent heartburn, less than 3 times a week. Antacids give faster relief, but H2 blockers last longer, maybe 6–10 hours versus 1 to 2 for antacids. Can even take them preventatively before meals. For frequent heartburn, though, twice daily H2 blockers or PPIs are usually better. But for erosive esophagitis, where there's actual damage, H2 blockers heal less than half of patients. PPIs are way superior there because they inhibit acid much more strongly.
And for ulcers?
For peptic ulcer disease, PPIs have pretty much replaced H2 blockers for acute ulcers. Faster symptom relief, higher healing rates. Treatment is usually 4 to 8 weeks. Depends on the ulcer and the cause, H. pylori or NSAIDs. If someone has to stay on NSAIDs with an active ulcer, you definitely need a PPI. And for H. pylori ulcers, you need that 14-day combo of a PPI plus antibiotics. No way around that.
What about just general indigestion, non-ulcer dyspepsia?
They're used OTC a lot for non-ulcer dyspepsia, yeah. But honestly, the benefit over placebo isn't super convincing in trials, so their role there is a bit murky.
Okay. And stress ulcers in the ICU.
Prevention of stress-related gastritis bleeding. That's important. In critically ill patients, they have a 1–3% risk of bleeding. Anti-secretory drugs, H2 blockers, or PPIs are key. They raise stomach pH, reduce bleeding risk significantly. For patients who can't take oral meds, IV H2 blockers or PPIs are the way to go. Continuous IV infusions of H2 blockers are generally preferred over single shots for keeping the pH elevated consistently. That sustained elevation is what you want.
What about side effects? Are they generally safe?
The good news is yes, H2 antagonists are very safe drugs. Adverse effects happen in less than 3% of people. Common stuff is mild. Diarrhea, headache, fatigue, muscle aches, constipation. However, some studies, especially in ICU patients, suggest IV H2 blockers and maybe even PPIs might increase the risk of hospital-acquired pneumonia.
Any specific worries?
A few things to keep in mind. CNS effects, though rare, can happen. Confusion, hallucinations, agitation more likely with IV H2 blockers, especially in elderly ICU patients or those with kidney or liver problems. Cimetidine seems to be implicated more often. Very rare in outpatients, though.
And cimetidine has some unique issues, right?
Yes, cimetidine is special, and this is a key point for professionals. It uniquely messes with androgen receptors and estrogen metabolism and increases prolactin. Long-term or high-dose use can lead to gynecomastia, breast enlargement in men, or impotence. In women, galactorrhea, inappropriate milk production. These effects are specific to cimetidine, generally not seen with the others.
Anything else rare?
Other rare things. They cross the placenta, so use in pregnancy only if really needed. Secreted into breast milk. Very rarely cause blood problems or slow heart rate. Rapid infusion can cause bradycardia and low blood pressure because of heart H2 receptors, so always infuse IV slowly over 30 minutes. And rarely cause temporary liver enzyme bumps.
Okay, and drug interactions. You mentioned cimetidine.
Right, drug interactions. Cimetidine is the main offender here. It interferes with several key liver enzymes, the cytochrome P450 system, specifically CYP1A2, 2C9, 2D6, 3A4. This can prolong the half-lives of other drugs metabolized by these pathways, potentially leading to higher drug levels and side effects. Crucial point if patients are on multiple meds.
But the others are okay.
Nizatidine and famotidine have negligible CYP interaction. That's a big advantage. H2 blockers also compete with creatinine and some drugs, like prokinetic, for kidney tubule secretion. And interestingly, all of them except famotidine can inhibit the first-pass metabolism of alcohol in the stomach, potentially raising blood alcohol levels, though how clinically important that is debated. Okay, now on to the big guns. Proton-pump inhibitors, or PPIs. Since they arrived in the late 80s, they've absolutely revolutionized how we treat acid-peptic disorders. They're now among the most widely prescribed drugs on the planet, a true modern mainstay in GI.
And there are 6 key players in this class, right? Omeprazole, esomeprazole, lansoprazole, dexlansoprazole, rabeprazole, and pantoprazole. Structurally, they're all substituted benzimidazoles. They might look a bit like H2 blockers, but they work through a totally different mechanism. That's the key to why they're so much stronger.
Exactly. And some are isomers. Esomeprazole is the S isomer of omeprazole, the dexlansoprazole is the R isomer of lansoprazole. Most are oral, but esomeprazole and pantoprazole also come in IV forms for patients who can't take pills.
Now, here's where it gets really interesting, a real aha moment for understanding PPIs. They're given as inactive prodrugs. Tell us about that.
Right. So, to stop them being destroyed by stomach acid, the oral forms are cleverly designed with an enteric coating. This coating resists acid, lets the prodrug pass safely into the alkaline intestine where the coating dissolves and the prodrug gets absorbed.
Smart design.
Very. For patients who can't swallow pills or have feeding tubes, some capsules, not tablets, can be opened, and the tiny microgranules mixed with soft food or juice. There are also oral suspensions. And there's even an immediate release omeprazole powder mixed with sodium bicarbonate. The bicarb protects the drug from acid right in the stomach, allowing rapid absorption and a faster start to acid inhibition.
So once absorbed, how do they work?
Okay, so once they're absorbed, PPIs are lipophilic weak bases. This lets them easily cross cell membranes into highly acidic places, specifically the parietal cell canaliculus, a tiny channel where acid gets secreted. There, the prodrug quickly gets protonated and becomes concentrated over 1,000-fold. It's called Henderson-Hasselbalch trapping.
Trapped in the acid pocket.
Exactly. It's like a one-way door. The drug gets in, gets protonated, and can't easily leave. In that acidic environment, the prodrug converts to its active form. This active form then forms a covalent disulfide bond with the H plus K plus ATPase, the proton pump. This bond is crucial. It irreversibly inactivates the pump. That irreversible binding is the secret to their long-lasting profound effect.
Okay, what about pharmacokinetics? How quickly do they work? How long do they last?
Well, immediate release omeprazole has the fastest onset. But for long-term daily use, the subtle pharmacokinetic differences between the various PPIs don't really matter much clinically in terms of overall effect. A really key point for patients. Their bioavailability, how much drug actually gets into the system, is cut by about half by food.
Ah, so take on an empty stomach.
Definitely. Take them on an empty stomach, usually 30-60 minutes before breakfast. Why? Because when you're fasting, only about 10% of your proton pumps are actively pumping acid and are susceptible to being blocked. Timing the dose hits the pumps when they're most active after the meal stimulus arrives. Maximize the effect.
And despite a short half-life in the blood, about 1.5 hours, the acid inhibition lasts up to 24 hours. How?
Again, it's that irreversible inactivation of the pump. It takes at least 18 hours for the parietal cells to make new pump molecules and put them in the membrane. This means it takes 3-4 days of daily dosing to reach full acid-blocking potential. That's why patients don't feel 100% better on day one. And similarly, it takes 3-4 days after stopping the drug for full acid secretion to come back.
How are they metabolized? Any kidney issues?
They undergo rapid first pass and systemic liver metabolism, very little kidney clearance. So usually, no dose reduction needed for kidney problems or mild to moderate liver disease, but definitely considered in severe liver impairment. And remember, that proton pump, the H plus K plus ATPase, is unique to the parietal cell. That explains their specificity. For IV forms and fasting patients, they only hit actively secreting pumps. So for maximum effect in the first day or two, you need continuous infusions or repeated shots to keep hitting newly activated pumps. Pharmacokinetically, they're pretty ideal. Short half-life, get concentrated and activated right where they need to work, and long effect due to irreversible binding.
And pharmacodynamically, this is where they really outshine the H2 blockers, right?
Absolutely. This is their superiority. Unlike H2 antagonists, PPIs inhibit both fasting and meal-stimulated acid secretion because they block that final common pathway, the proton pump itself. In standard doses, they're incredibly potent, inhibiting 90–98% of 24-hour acid secretion.
Wow, almost complete shutdown.
Pretty much. And even though different PPIs might keep the pH above 4 for slightly different durations at equivalent doses, say esomeprazole 40 mg versus pantoprazole 40 mg, these differences have little clinical importance overall. The profound, lasting suppression comes from that irreversible pump inactivation, more than subtle pharmacokinetic variations. It's about that deep, sustained impact.
Okay, let's talk clinical uses. They're the gold standard for many things.
Definitely. For GERD, PPIs are the most effective drugs for erosive reflux disease where there's damage, and for esophageal complications like strictures or Barrett esophagus. Also good for those extraesophageal symptoms like asthma or chronic cough caused by reflux. Once daily dosing gives relief and healing in 85–90% of patients. Maybe 15% need twice daily dosing for more severe cases.
And long-term GERD, can people stop them?
That's the issue. Symptoms often come back in over 80% of patients within just 6 months of stopping a PPI. So, for erosive esophagitis or complications, long-term daily maintenance, full or half dose, is usually needed. Many with milder, non-erosive GERD can manage with intermittent or on-demand PPIs or H2 blockers, though.
What about treating GERD without an endoscopy first? Empiric treatment.
Yeah, that's common. Empiric PPI treatment works well for 70–80% of patients with symptoms, much better than the 50–60% with H2 blockers. While PPIs are often first line now, because they work well and costs have come down, especially given the safety concerns with long-term PPI use we need to talk about. For those extraesophageal things, asthma, cough, laryngitis, chest pain thought to be from reflux, you usually need sustained. Twice daily PPIs for at least 3 months to really see if reflux is the culprit. For peptic ulcer disease, PPIs again offer faster symptom relief and ulcer healing than H2 blockers for both duodenal and gastric ulcers. They heal over 90% of duodenal ulcers in 4 weeks, gastric ulcers in 6 to 8 weeks. Highly effective.
And for H. pylori-associated ulcers, you mentioned combination therapy.
Yes, 2 critical goals there. Heal the ulcer, A&D, get rid of the bug. The best regimens combine 2 antibiotics with a PPI. The PPI helps in a couple of ways. Minor direct effect on the bacteria, but more importantly, raising the stomach pH makes the antibiotics work much better against H. pylori.
But the standard triple therapy isn't always recommended now.
Right. The traditional PPI twice daily plus clarithromycin and either amoxicillin or metronidazole for 14 days. It's failing more often due to rising clarithromycin resistance. This really highlights how treatment guidelines have to evolve based on resistance patterns.
So what's the alternative? Quadruple therapy.
Exactly. Quadruple therapy is often first line now if you suspect resistance. 2 main 14-day options.
PPI twice daily, plus bismuth subsalicylate, plus metronidazole, plus tetracycline, all given 4 times daily. There's actually a combo capsule to make that easier.
PPI twice daily, plus amoxicillin, plus clarithromycin, plus metronidazole, all given twice daily.
And after the antibiotics,
Keep the PPI going, once daily, for 4-6 weeks total to ensure the ulcer heals fully. And absolutely critical, confirm eradication in everyone. Fecal antigen test, urea breath test, or endoscopy with biopsy about 4 weeks after finishing antibiotics. And here's a crucial tip for you. Stop the PPI therapy 2 weeks before the test to avoid false negatives. You don't want to just suppress the bug, you need to know it's gone.
what about NSAI-associated ulcers? If someone has to keep taking NSAIs.
If the NSA can be stopped, H2 blockers or PPIs heal the ulcer quickly. But if NSA therapy must continue, PPIs are much more reliable for promoting healing. And remember, asymptomatic ulcers develop in 10–20% of frequent NSAI users, with serious complications in 1–2% per year. Once daily PPIs are highly effective at preventing these ulcers and complications in patients needing ongoing NSAIDs, including aspirin, crucial prophylactic role for preventing rebleeding from peptic ulcers, especially high-risk ones with visible vessels or clots seen on endoscopy. PPI significantly cut the rebleeding risk when given for 3 to 5 days. High-dose oral or often continuous IV infusion for immediate strong effect. The thinking is that keeping the stomach pH above 6 helps clots form and stabilize. A common IV regimen is an 80 mg bolus, then 8 millibар continuous infusion.
What about non-ulcer dyspepsia and stress bleeding prevention in the ICU?
For non-ulcer dyspepsia, PPIs have only modest efficacy, maybe 10–20% better than placebo. Not clearly superior to H2 blockers or placebo, despite being used a lot. For preventing stress bleeding in critically ill patients, PPIs are given orally, often via NG tube or IV. The immediate-release oral omeprazole formulation is FDA approved for this via NG tube. Suspensions might be preferred for NG tubes, similar efficacy to IV, lower cost, easier.
But if someone can't take anything by mouth or tube,
Right, if there's no enteral access or they have an ileus, IVH2 antagonists might actually be preferred for stress prophylaxis. They have proven efficacy in controlled trials. PPIs are used a lot IV in this setting, but we lack controlled trial data confirming efficacy or optimal dosing there.
and for rare things like gastronoma.
Right, gastronomas or other hypersecretory conditions cause massive acid production, leading to severe ulcers, esophagitis, malabsorption. PPIs give excellent acid suppression. You have to titrate the dose to get basal acid output below 510 milliliter a car. So I mean really high doses like omeprazole, 60 and 120 milliliters per day, highly individualized.
Okay, let's shift to adverse effects. PPIs were considered super safe, but now there are concerns, especially long-term.
Exactly. While generally very safe, a number of recent safety concerns have popped up, mostly from retrospective observational studies. It's tough to prove causation versus just association or confounding factors in those studies. The guiding principle for you as a professional: use the lowest effective dose for the shortest time needed. Carefully weigh risks versus benefits for long-term use. General side effects like diarrhea, headache, abdominal pain are mild, maybe 1–5%, only slightly more than placebo.
What about specific concerns? Kidneys? Dementia?
Yeah, kidney concerns. Large observational studies link PPIs to increased risk of acute interstitial nephritis and chronic kidney disease compared to non-users or H2 blocker users. The mechanism: currently unknown. Ongoing research. Some early epidemiologic studies linked PPIs to dementia risk, but a meta-analysis did not find an increased risk, so that link seems less certain now. And pregnancy. Not teratogenic in animals, but human safety isn't fully established. Use with caution.
This raises a really important practical question. Stomach acid helps release B12 from food, helps absorb minerals like iron, calcium, magnesium. What happens when you suppress acid long-term?
Good question. A minor reduction in oral B12 absorption can happen, potentially leading to low B12 levels with prolonged therapy. Regarding bone and minerals, meta-analyses show a modest increase in hip fracture risk with long-term PPIs. Causal link isn't proven, but theories include reduced calcium absorption or maybe effects on osteoclasts, the bone breakdown cells. The FDA mandates warnings about possible increased risk of hip, spine, wrist fractures. So for long-term users, especially with osteoporosis risk factors, consider bone density monitoring and calcium supplements. The FDA also warned about rare but life-threatening hypomagnesemia, sometimes causing secondary low calcium, possibly due to reduced gut absorption, usually resolves when PPI is stopped. Magnesium monitoring is advised for patients also on diuretics.
And infections. Stomach acid is a barrier, right?
It is a vital barrier against ingested bacteria. PPIs do increase bacterial concentrations in the stomach, though the clinical significance isn't fully clear. Some studies report increased risk of community-acquired respiratory infections and hospital-acquired pneumonia, suggests compromising that acid barrier might have consequences, and definitely a link to Clostridium difficile. There's a 2 to 3-fold increased risk for both hospital and community-acquired C. diff infection in PPI users. Also, a small increased risk of other gut infections, Salmonella, Shigella, E. coli, Campylobacter, especially relevant for travelers, as lower acid lets more pathogens survive the stomach.
What about gastrin levels and rebound effects? Acid suppression messes with the feedback loop.
It does. PPIs lead to a 1.5 to 2-fold rise in median serum gastrin levels because the feedback is interrupted. Usually stays within normal range, but about 3% of patients see levels go above 500 pg/ml. Levels normalize within about 4 weeks of stopping the drug.
Can that high gastrin cause problems?
Well, the rise in gastrin can stimulate hyperplasia, more cells of ECL and parietal cells. This might cause a temporary rebound acid hypersecretion when you stop the PPI, causing dyspepsia or heartburn. Usually fades in 2 to 4 weeks. Now, what's fascinating, or maybe concerning, is in female rats on long-term PPIs, this hypergastrinemia caused gastric carcinoid tumors in areas of ECL hyperplasia.
Whoa, does that happen in humans?
While human PPI users can show ECL hyperplasia, carcinoid tumor formation hasn't been definitively documented. So right now, routine gastrin monitoring isn't recommended.
This leads to a common question. Does long-term acid suppression cause chronic inflammation, maybe leading to stomach atrophy, atrophic gastritis, or intestinal metaplasia, known risk factors for gastric cancer?
That's a really important question. The verdict so far is reassuring. An FDA advisory committee looked into this and concluded there's no evidence that long-term PPI therapy causes the type of atrophic gastritis or intestinal metaplasia linked to increased cancer risk. Routine H. pylori testing isn't recommended for long-term PPI users either, unless there's another reason. Interestingly, small, benign gastric fundic gland polyps can develop with long-term PPI use. They usually disappear after stopping the drug and are considered clinically insignificant.
Okay, what about drug interactions, besides the acid level changing absorption of some drugs?
Right. Decreased stomach acidity can alter absorption of pH-sensitive drugs like ketoconazole, itraconazole, digoxin-atazanavir. All PPIs are metabolized by liver P450 enzymes, mainly CYP2C19 and CYP3A4. But because PPIs themselves have short half-lives, clinically significant interactions are actually rare, despite the potential.
Are there specific PPIs to watch out for?
Some specifics are important for professionals. Omeprazole may inhibit the metabolism of clopidogrel, warfarin, diazepam phenytoin. Esomeprazole might also decrease diazepam metabolism. Lansoprazole could enhance the theophylline clearance. Rabeprazole and pantoprazole, on the other hand, have no significant drug interactions reported. That makes them potentially safer choices if interactions are a big concern.
Let's talk about the clopidogrel controversy. That generated a lot of buzz.
It really did. The FDA issued a warning about a potential interaction between clopidogrel, that antiplatelet drug, and PPIs. Clopidogrel is a prodrug. It needs activation by the liver enzyme CYP2C19. Several PPIs, especially omeprazole, esomeprazole, lansoprazole, dexlansoprazole, also use CYP2C19 for metabolism. So the worry was PPIs could compete, reduce clopidogrel activation, weaken its antiplatelet effect, and potentially increase cardiovascular events.
Did that turn out to be true?
Well, several large retrospective studies did report more serious cardiovascular events in patients taking both. But importantly, 3 smaller prospective randomized trials did not find an increased risk. So the evidence is conflicting. It's a tough clinical call. The current advice: if a patient on clopidogrel absolutely needs a PPI, consider pantoprazole or rabeprazole because they have minimal CYP2C19 inhibition, lessening the potential interaction risk.
Okay, moving beyond just taming acid, another key strategy in GI pharmacology is reinforcing the gut's own mucosal shields. The gastroduodenal lining, your stomach and upper small intestine, has these incredibly sophisticated built-in defenses. It acts like a natural barrier against all those corrosive things.
Absolutely. It's like a multi-layered fortress, isn't it? You've got mucus and these tight junctions between epithelial cells acting as physical barriers, stopping acid and pepsin from seeping back.
Right.
Then there's bicarbonate secretion, creating that crucial pH gradient, keeps it neutral, maybe pH 7 right at the surface, while the stomach lumen is super acidic, pH 1 or 2.
Huge difference. And good blood flow is vital too, right? Brings bicarbonate, nutrients, washes away bad stuff. Injured lining gets quickly repaired by restitution cells literally migrate to seal small erosions. And finally, those mucosal prostaglandins are key, stimulating mucus, bicarb, blood flow. Really crucial for maintaining that delicate balance.
So the drug strategy for these mucosal protective agents is basically to potentiate or boost these natural defenses. We're essentially giving your body's own shields an extra bit of help, helping it repair itself and stand up to those aggressive factors.
Sucralfate is a fascinating one. It acts quite literally like a Band-Aid for ulcers, doesn't it? Chemically, it's a salt of sucrose complex to sulfated aluminum hydroxide.
Yeah, and how it works is pretty unique, very targeted. In water or acidic solutions, it forms this thick, sticky paste. What's special is that this paste selectively binds to ulcers or erosions, sticks there for up to 6 hours.
How does it stick just to the ulcer?
It breaks down into negatively charged sucrose sulfate and an aluminum salt. That negatively charged sucrose sulfate is thought to bind to positively charged proteins exposed at the ulcer base, forms a physical barrier, protecting it from more acid and pepsin damage. It also has some secondary benefits, stimulates mucosal prostaglandin and bicarbonate secretion, further boosting those natural defenses.
And pharmacokinetics. Does much get absorbed?
Very little. Less than 3% of the intact drug and aluminum gets absorbed. The rest is just excreted in the feces. It's usually given 1 gram 4 times daily on an empty stomach, at least an hour before meals. Needs that empty stomach to bind effectively. Its clinical uses are pretty limited now, though, largely replaced by stronger acid suppressants.
But still used sometimes?
Yeah, it can reduce upper GI bleeding in critically ill ICU patients, given as a slurry via NG tube, though it's slightly less effective than IVH2 blockers. Some clinicians still like it for preventing stress bleeding because of those concerns that acid-blocking drugs might increase pneumonia risk.
Side effects, since it's not absorbed much.
Exactly. Systemic side effects are virtually non-existent. Big advantage. Constipation occurs in about 2% of people due to the aluminum salt. Because a tiny bit of aluminum is absorbed, prolonged use needs caution in renal insufficiency, risk of accumulation. And like antacids, it can bind to other meds, impairing their absorption. So you need to space out the doses, give it at least an hour away from other drugs.
Our bodies make their own protective messengers in the gut, right? The GI mucosa naturally synthesizes prostaglandins, mostly E and F types, for local protection. They're crucial for keeping that gut lining intact.
And misoprostol is a synthetic version, a methyl analog of PGE1. It's approved for specific GI conditions. Orally, it's absorbed fast, metabolized to an active form. But its serum half-life is really short, under 30 minutes. That means it needs dosing 3 to 4 times a day.
That's inconvenient.
Big time. A major barrier to adherence. It's mostly excreted in urine, but dose reduction isn't needed for kidney problems. Misoprostol has both acid inhibitory effects and strong mucosal protective properties. It's thought to directly stimulate mucus and bicarbonate secretion, enhance mucosal blood flow, really strengthening those natural defenses.
How effective is it?
It can significantly reduce NSAID-induced ulcers down to less than 3% and cut ulcer complications by half. It's specifically approved for preventing NSAID-induced ulcers in high-risk patients who have to stay on NSAIDs.
But you don't see it used that much.
No. And what's fascinating here is, despite being effective, misoprostol never really caught on widely. Why? Mostly due to its high side effect profile, dose-dependent abdominal pain and diarrhea, plus that inconvenient multiple daily dosing. Often, the side effects just outweigh the benefits for many patients.
Okay, bismuth compounds, 2 main ones available. Bismuth subsalicylate, that's the non-prescription stuff, like Pepto-Bismol, kaopectate, and bismuth subcitrate potassium, often in prescription combos for H. pylori.
Right. Pharmacokinetically, bismuth subsalicylate breaks down fast in the stomach. The salicylate part gets absorbed, but over 99% of the bismuth itself ends up in the stool. Very little systemic absorption, less than 1%. What little gets absorbed is stored in tissues, slowly excreted by the kidneys. The salicylate, like aspirin, is readily absorbed and handled by the kidneys.
How do they work? Is it just coating?
The exact mechanisms aren't fully known, but coating is part of it. Bismuth literally coats ulcers and erosions, forming a protective layer against acid and pepsin. It might also stimulate prostaglandin, mucus, and bicarbonate secretion, helping the gut's own defenses, similar to misoprostol. But it's more than just protection. Bismuth subsalicylate helps with acute infectious diarrhea, reduces stool frequency and liquidity. That's thought to be the salicylate part inhibiting intestinal prostaglandin and chloride secretion. Plus, bismuth has direct antimicrobial effects and binds enterotoxins. That's why it's useful for preventing and treating travelers' diarrhea. And crucially, bismuth compounds have direct activity against H. pylori. That makes them key in those quadruple eradication regimens we talked about earlier.
So, clinically, OTC for indigestion, diarrhea.
Yep, widely used OTC for nonspecific dyspepsia and acute diarrhea. Bismuth subsalicylate for preventing travelers' diarrhea. And, as we mentioned, vital in those 4 drug regimens for H. pylori eradication. Like a PPI twice daily plus bismuth subsalicylate, tetracycline, and metronidazole, all 4 times daily. Or using that combo capsule with bismuth subcitrate shows their versatility. Safety-wise, bismuth formulations are generally excellent. Very safe profile. The most common side effect, totally harmless, is blackening in the stool. Can be confused with GI bleeding, so important to tell patients.
Right, don't panic.
Exactly. Liquid forms might also cause harmless darkening of the tongue. Should only be used short-term, avoid in renal insufficiency due to that slight bismuth absorption. Now, prolonged use of some bismuth compounds historically rarely caused bismuth toxicity, encephalopathy, ataxia, confusion, seizures. But this is not reported with the common forms, bismuth subsalicylate or bismuth citrate. High doses of bismuth subsalicylate, though, can lead to salicylate toxicity, like too much aspirin, so dosing matters.
Okay, let's shift gears. We're moving from the chemical environment of the stomach to the mechanics of digestion, the intricate world of gut motility. Your gut actually has its own brain, this incredibly sophisticated semi-autonomous network called the enteric nervous system, or ENS.
It really is like a second brain. The ENS is made of interconnected networks of nerve cells and fibers, mainly in 2 layers, the submucosal plexus and the myenteric plexus, which sits between the muscle layers. These networks send fibers to the mucosa and muscle, and while external nerves connect the ENS to your actual brain, what's truly remarkable is the ENS can independently regulate GI motility and secretion. It's largely autonomous.
Wow. So if the gut has its own brain, how can we influence it therapeutically?
That's the key question. And what's fascinating here is the crucial role of serotonin 5-HT in this system. Enterochromaffin, or EC, cells in the gut lining release 5-HT. It acts locally. This serotonin stimulates 5-HT3 receptors on external nerves, sending signals to the brain, causing nausea, vomiting, or pain.
Okay, that's the bad side.
But serotonin also drives movement. It stimulates 5-HT1P receptors on intrinsic gut nerves, the IPANs. These contain messengers like CGRP and acetylcholine. These IPANs connect to myenteric interneurons. Plus, 5-HT4 receptors on the IPANs seem to boost the release of CGRP or acetylcholine, promoting reflex activity. And these myenteric interneurons, they control the peristaltic reflex, those wave-like contractions moving food along. So serotonin is a really powerful multitasking player in gut sensation and movement.
Are there other players besides serotonin?
Oh, yeah. Motility is a hormone that can directly stimulate excitatory nerves or muscle cells to boost motility. Dopamine, conversely, acts as an inhibitor, slowing down esophageal and gastric contractions. So this raises that important question again. How exactly do we harness these complex signals, this gut brain, for therapeutic effect with specific drugs? Understanding this is fundamental to treating motility disorders.
And drug development has focused mainly on which serotonin receptors?
Right. While there are tons of serotonin receptor subtypes, over 14, for GI applications, drug development has largely focused on 2 main targets: 5-HT3 receptor antagonists to block those nausea pain signals, and 5-HT4 receptor agonists to stimulate movement. Those are the primary levers we try to pull.
Yeah.
Okay, prokinetic agents. These are specifically designed to stimulate gut motor function. The goal might be increasing lower esophageal sphincter pressure for GERD, improving gastric emptying for gastroparesis, stimulating the small intestine for ileus or pseudo-obstruction, or enhancing colon transit for constipation. Unfortunately, we only have a limited number of these agents available, which really shows how challenging it is to precisely tweak this complex system.
Let's start with colon and mimetic agents, bethanyl, neostigmine.
Right. Bethanyl stimulates muscarinic M3 receptors on muscle and nerve junctions, basically mimicking acetylcholine to trigger contractions. It was used historically for GERD and gastroparesis, but it has too many cholinergic side effects, think generalized parasympathetic overdrive, and we have safer options now. Seldom used. Neostigmine is an acetylcholinesterase inhibitor. It stops acetylcholine breakdown, boosting its effects on stomach, small intestine, and colon emptying. 5-rated neostigmine, maybe 2 mg, is mainly used in hospitalized patients with acute large bowel distension that's acute colonic pseudoobstruction or Ogilvie syndrome. Often causes prompt colon evacuation in that specific setting. Side effects, excessive salivation, nausea, vomiting, diarrhea, slow heart rate. Use carefully.
Okay, what about metoclopramide and domperidone? They work on dopamine.
Exactly. They're dopamine D2 receptor antagonists. In the gut, dopamine normally inhibits cholinergic muscle stimulation, acting like a brake. So by blocking dopamine, these drugs essentially release the brake, increasing motility. Specifically, they boost esophageal peristalsis, increase lower esophageal sphincter pressure, and enhance gastric emptying. Good for stomach issues, but importantly, they have no effect on small intestine or colonic motility.
And they have that anti-nausea effect, too.
Yes, a really important additional action. They also block D2 receptors in the brain's chemoreceptor trigger zone in the medulla that gives them potent anti-nausea and antiemetic action, useful beyond just motility.
So clinical uses.
For GERD, rarely used alone now, may be combined with acid suppressors for persistent regurgitation or refractory heartburn if there's also delayed gastric emptying. For impaired gastric emptying, like after stomach surgery or diabetic gastroparesis, they're widely used, often first line. Metoclopramide can also help advance feeding tubes in the hospital. For non-ulcer dyspepsia, maybe symptomatic improvement in a few patients who failed everything else. And because of that antiemetic effect, commonly used for preventing vomiting. Domperidone is also sometimes used off-label to promote postpartum lactation because it raises prolactin.
Okay, adverse effects. Metoclopramide seems to have significant CNS issues.
Yes, this is crucial for professionals to understand. Metoclopramide's most common side effects are CNS-related. Restlessness, drowsiness, insomnia, anxiety, agitation, 10–20% of patients, especially elderly. More seriously, extrapyramidal effects, dystonias, akathisia, Parkinsonian features occur acutely in 25% with high doses, 5% with long-term therapy. And the big one, tardive dyskinesia. That's a potentially irreversible movement disorder linked to prolonged use. So long-term metoclopramide should really be avoided unless absolutely necessary, especially in the elderly. Both drugs can also elevate prolactin, leading to galactorrhea, gynecomastia, impotence, menstrual issues due to that dopamine block.
But domperidone is better tolerated.
Much better tolerated, yes. The key difference, it doesn't significantly cross the blood-brain barrier, so those neuropsychiatric and extrapyramidal effects are rare. A major advantage if you need a prokinetic without the CNS baggage.
Okay, lastly in prokinetics, macrolides, like erythromycin, that's an antibiotic.
It is. But macrolides, like erythromycin, also directly stimulate motilin receptors on GI smooth muscle. They mimic the natural hormone motilin, promoting those migrating motor complex waves, the gut's housekeeping.
So used for gastroparesis sometimes.
Yeah, patients with gastroparesis who don't respond to metoclopramide or domperidone might try oral erythromycin. But a big limitation is that tolerance rapidly develops, limits its chronic use. RV erythromycin can be useful for acute flare-ups of gastroparesis, though, and also helps empty the stomach of blood quickly before an endoscopy if someone has an upper GI bleed. Clears the view. All right, let's move on to laxatives. The big picture. Most people probably don't need them regularly, but they are incredibly widely self-prescribed. For most, occasional constipation is best prevented with lifestyle stuff. High-fiber diet, plenty of fluids, regular exercise, and, just going when you need to go.
Simple advice, but often ignored.
Exactly. If those changes don't work, a medical evaluation is really recommended before starting long-term laxative use, just to rule out any underlying problems. Now, laxatives are classified by their main mechanism, but remember, many work in multiple ways.
Okay, first up, bulk-forming laxatives. How do they work?
Pretty simply, actually. They're indigestible hydrophilic colloids. They absorb water, form a bulky, soft gel. This gel distends the colon, which stimulates peristalsis, helps things move naturally. Common examples, natural plant stuff like psyllium, metal cellulose, or synthetic fibers like polycarbophyll. A common side effect, especially at first, is bacterial digestion of these fibers in the colon can cause more bloating and gas. Can be uncomfortable.
Next, stool surfactant agents or softeners.
Right. These soften the stool by letting water and fats penetrate it. Makes it easier to pass without straining. Docusate, oral or enema, is commonly used in hospitals to prevent constipation, minimize straining, especially post-op or postpartum. Glycerin suppositories work similarly, locally.
What about mineral oil?
Mineral oil. It's a clear, viscous oil. Lubricates the stool, slows water absorption from it. Used sometimes for fecal impaction, maybe in kids or debilitated adults. Not very tasty. And a crucial warning for any professional. Aspiration can cause severe lipidogenitis, very dangerous lung inflammation. Plus, long-term use messes with absorbing fat-soluble vitamins A, D, E, K. Not great for chronic use.
Okay, then osmotic laxatives, they work by drawing water in.
Exactly. The colon can't concentrate or dilute fluid. It stays isotonic. So osmotic laxatives are soluble but non-absorbable things that increase stool liquidity by pulling water into the stool via osmosis. Makes it softer, easier to pass.
What are some common examples?
Non-absorbable sugars or salts. Magnesium hydroxide, milk of magnesia, very common for acute or chronic constipation. but shouldn't be used long-term in kidney failure due to hypermagnesemia risk. Sorbitol and lactulose are non-absorbable sugars, also for chronic constipation. Colonic bacteria ferment them, though, causing gas and cramps.
And the ones used for colonoscopy prep. The purgatives.
Right. High doses of osmotics cause rapid bowel evacuation purgation, usually within 1-3 hours. Moves a lot of water into the distal small bowel and colon, leading to high-volume liquid stool. Used for acute constipation sometimes, or bowel cleansing before procedures like colonoscopy. Examples: magnesium citrate, sulfate solution, or that magnesium oxide sodium picosulfatecitrate combo.
You mentioned sodium phosphate preps have risks.
Yes, critical caution here. Sodium phosphate purgatives are used infrequently now. Risk of electrolyte problems: high phosphate, low calcium, high sodium, low potassium. Often minor in healthy folks, but can cause serious issues like cardiac arrhythmias or acute kidney failure from calcium phosphate deposits and nephrocalcinosis. So, critical warning: avoid sodium phosphate preps in frail elderly patients, those with kidney problems, significant heart disease, or anyone who can't stay well hydrated during the prep. Crucial contraindications, and with all purgatives, hydration is absolutely key. Got to replace that fluid loss. Patients need to drink plenty of clear fluids.
What about the balanced polyethylene glycol PEG lavage solutions? They seem very common for prep.
They are, and generally very safe. They're balanced isotonic solutions with an inert, non-absorbable sugar, PEG, plus electrolytes. Designed so no significant fluid or electrolyte shifts occur in the body. Very safe for almost everyone, even heart or kidney patients. For optimal cleansing, usually 1 to 2 liters ingested rapidly evening before, and another 1-2 liters 4 to 6 hours before the procedure. Split dose works best. For chronic constipation, smaller daily doses of PEG powder mixed in water juice can be used. And unlike sorbitol or lactulose, PEG doesn't cause significant cramps or gas. Big plus for comfort and getting patients to actually complete the prep.
Okay, next category: stimulant laxatives or cathartics.
Right. They trigger bowel movements through mechanisms that are still a bit fuzzy. Thought to involve direct stimulation of the enteric nerves and promoting colon electrolyte fluid secretion. There used to be worries about long-term use causing dependence or nerve damage, leading to an inactive colon. But newer research suggests long-term use is generally safe for most. They might be needed long-term, though, for neurologically impaired or bedbound patients.
What types are there?
Anthraquinone derivatives, aloe, senna, cascara. Natural plant products, poorly absorbed, broken down by colon bacteria. Effect in 6-12 hours orally, 2 hours rectally. Chronic use causes melanosis coli, harmless brown colon staining. No proven link to colorectal cancer, despite old concerns. Then, diphenylmethane derivatives like Bisacodil, tablet and suppository. Used for acute or chronic constipation, and with PEG for colon cleansing. Works in 6-10 hours orally, 30-60 minutes rectally. Minimal absorption seems safe long-term, too.
Moving to newer classes: chloride secretion activators, lubiprostone.
Lubiprostone. It's a prostanoic acid derivative. Stimulates the type 2 chloride channel, CLC2, in the small intestine. This boosts chloride-rich fluid secretion into the gut, which stimulates motility, shortens transit time. Impressively, over half of patients have a bowel movement within 24 hours of one dose. Dose for chronic constipation is 24 milliframes orally, twice daily. Seems to keep working long-term, but constipation comes back if you stop it. Minimal absorption. Category C for pregnancy: increased fetal loss in guinea pigs. Can cause nausea, maybe up to 30%, possibly due to delayed gastric emptying. Taking it with food helps. Then there are linaclotide and prokinetic, minimally absorbed, short amino acid peptides. They stimulate chloride secretion differently. They bind and activate guanylate cyclase C on the gut lining. This increases cyclic GMP, which activates the CFTR channel, yes, the same one involved in cystic fibrosis, leading to chloride-rich secretion and faster transit. Both approved for chronic constipation, linaclotide also for IBS-C. They give maybe 1 to 2 extra bowel movements per week, usually starting in the first week. Stop the drug. Frequency goes back to normal within a week. Main side effect: diarrhea. Up to 20%, can be severe in a few, leads to stopping the drug in 4-5%. Negligible absorption, but contraindicated in kids due to reports of death in baby mice from dehydration. A related drug, crofelemer, inhibits CFTR, used for HIV drug diarrhea, opposite effects, same pathway target.
Okay, now opioid receptor antagonists. For opioid-induced constipation, right? OIC.
Exactly. Opioids cause constipation, increase non-moving contractions, prolonged transit, increase water absorption, mainly via MOOP, opioid receptors in the gut. Can also prolong post-op ileus. Big problem for patients needing opioids.
So the solution: antagonists that don't cross into the brain.
Precisely. 4 selective opioid antagonists available: naldomidine, naloxone, methylnaltrexone bromide, and alvimopan. Key insight: they don't readily cross the blood-brain barrier, so they block peripheral gut receptors without messing with the central pain relief effects. Best of both worlds, potentially.
How are they used?
Naltamidine, 0.2 mg QD, and naloxone, 12.525 mg QD, are approved for OIC in chronic non-cancer pain patients who haven't responded well to regular laxatives. Trials show 42-52% get O3 spontaneous bowel movements, weak versus 30-35% placebo. Both are metabolized by liver CYP3A system, so watch for interactions with CYP3A4 inhibitors inducers. Methylnaltrexone is approved for OIC in chronic non-cancer pain and palliative care patients failed by other agents. Oral, 450 mg, or subcutaneous injection, 0.15 mg Kildan every 1-2 days. Dose reduction needed for kidney liver impairment, no significant drug interactions. Alphamolpan is approved for short-term use only, max 7 days to shorten post-op ileus after bowel resection. Helps patients recover faster, given orally before surgery, twice daily after. Critical point. Restricted to hospitalized patients only due to possible cardiovascular toxicity concerns. Special program needed. Adverse effects for these. Common across naltamidine, naloxone, methylnaltrexone, nausea, abdominal pain, diarrhea. Uncommon but serious. Opioid withdrawal symptoms. GI perforation, especially if underlying gut issues exist. Need careful patient selection. Finally, within motility, serotonin 5-HT4 receptor agonists. These receptors are all over the GI tract. Activating them boosts cyclic AMP, facilitating neurotransmitter release acetylcholine from excitatory nerves, nitric oxide from inhibitory ones, CGRP and acetylcholine from afferent nerves. Net result, enhanced acetylcholine release, stimulating motility throughout the gut. In the colon, this means contraction of longitudinal muscle, relaxation of circular muscle, leading to those powerful high-amplitude propagating contractions, HKPCs, pushing things forward. Very targeted way to promote movement.
And the drug here is prucalopride.
Yes. A high-affinity 5-HT4 agonist. Approved for chronic constipation, 2 mg QD. Increases strength and number of colonic HAPCs, cuts transit time by about 12 hours. Big improvement. Unlike older drugs like cisapride, tigecerod, which were pulled due to heart risks, prucalopride doesn't seem to significantly affect HERGK plus channels or 5-HT1B receptors. No identified cardiovascular risk. Much safer profile.
How well does it work?
Trials show 1938% of chronic constipation patients get HA3 spontaneous bowel movements weak. Significant improvement over placebo. Prucalopride is well absorbed, mostly excreted unchanged by kidneys. Dose reduction needed for severe renal impairment. Frequent side effects, nausea, abdominal pain, diarrhea, lead to stopping in up to 5%. No significant drug interactions identified.
Okay, let's pivot. Now to the other side of motility when things move too fast.
Anti-diarrheal agents. They can be used safely for mild to moderate acute diarrhea, providing symptomatic relief.
But there are critical situations where you shouldn't use them, right?
Absolutely. A critical point for clinicians and for you listening. These agents should not be used if someone has bloody diarrhea, high fever, or signs of systemic toxicity, like severe abdominal pain or dehydration. Using them then can actually worsen things by trapping pathogens or toxins inside. Also stop them if diarrhea gets worse despite treatment. Beyond acute stuff, they're also used to control chronic diarrhea in conditions like IBS or IBD.
We already talked about opioids causing constipation. Here, we actually use that effect.
Exactly. We leverage it. Opioid agonists increase colonic segmenting activity, inhibiting cholinergic nerves, leading to longer transit time, more water absorption. They also decrease mass movements and the gastrocolic reflex. Slows everything down. While all opioids do this, CNS effects and addiction potential limit most of them.
But loperamide is different, the OTC one.
Right. Loperamide is a non-prescription opioid agonist that crucially does not cross the blood-brain barrier. No analgesic properties, no addiction potential. Safe OTC choice. Interestingly, tolerance doesn't seem to develop with long-term use. Usual dose is 2 mg, 1 to 4 times a day.
And dephenoxylate, that's prescription.
Yes, prescription opioid agonist, no analgesic effect at standard doses. But higher doses can cause CNS effects, and prolonged use can lead to dependence. That's why commercial preps often have a tiny bit of atropine added to discourage abuse. The atropine's anticholinergic effects might also help with the diarrhea.
What about aloxetiline, newer one for IBSD?
Right. A prescription opioid agonist, high affinity for the mu receptor, lower for delta. Oral intake slows colon transit, increases fluid absorption. Approved specifically for diarrhea-predominant IBS, IBSD, usually 75-100 mg twice daily. Trials showed about 30% on 100 mg twice daily got significant improvement in pain and diarrhea versus 16% placebo. Constipation can happen, about 8%.
Any major risks with aloxetiline?
Yes, a critical risk. About 1% of patients get sphincter of spasm, usually within the first week. Can cause severe abdominal pain, pancreatitis, elevated liver pancreatic enzymes. Because of this, aloxetiline should not be used in patients with a history of
pancreatitis, alcoholism, or known sphincter of Oddi disease. Caution needed if someone's had their gallbladder out, up to 5% risk of complications from spasm. Lower dose, 75 milligram BID recommended for them, or those with liver disease or side effects. Careful patient selection is key.
Okay, bile salt binding resins. What problem do they solve?
It's about bile salt handling. Normally, conjugated bile salts get absorbed way down in the terminal ileum. But if you have disease there like Crohn's or had that part surgically removed, you get bile salt malabsorption. These unabsorbed bile salts hit the colon, irritate it, and cause colonic secretory diarrhea.
So the resins bind the bile salts.
Exactly. Resins like cholestyramine, cholestipol, or cholecivellum bind the excess fecal bile acids, stopping them from irritating the colon and causing diarrhea. Available as powders, pills, usually taken 1 to 3 times daily before meals. Side effects: bloating, gas, constipation, sometimes fecal impaction. And if someone already has low bile acid levels, binding more can actually worsen fat malabsorption because you need bile acids for that.
Drug interactions.
Cholestyramine and cholestipol bind lots of other drugs, reducing their absorption. So don't give them within 2 hours of other meds. Cholecivellum seems to have minimal effect on other drug absorption. Safer choice if someone's on multiple medications.
Then there's octreotide, which mimics somatostatin. Somatostatin itself is this key regulatory peptide all over the GI tract, pancreas, hypothalamus. And what's fascinating is its incredibly wide range of effects. It's like a master regulator.
It really is. It inhibits the secretion of tons of hormones and transmitters: gastrin, CCK, glucagon, insulin, VIP, serotonin, you name it. Reduces intestinal fluid and pancreatic secretion. Slows GI motility. Inhibits gallbladder contraction. Reduces portal and splanchnic blood flow. Inhibits some pituitary hormones, like a universal turn-down-the-volume switch.
But natural somatostatin doesn't last long.
Right. Its clinical use is limited by a super short half-life, like 3 minutes, impractical. Octreotide, though, is a synthetic octapeptide. Similar actions, but much longer half-life. 1.5 hours for ED, 6-12 hours subcutaneous. There's even a once-monthly depot injection for chronic use.
So clinically, where is octreotide used?
For endocrine tumor effects like advanced symptomatic GI neuroendocrine tumors, carcinoid V. pipoma, causing severe secretory diarrhea, flushing, wheezing, octreotide dramatically cuts those symptoms by blocking hormone secretion. Might even slow tumor growth sometimes. For other diarrhea causes, it inhibits intestinal secretion and has dose-related effects on motility. Interestingly, low doses, 50 milligram SC, can actually stimulate motility. While higher doses, 100, 250 millicurie SC, inhibit motility. Those higher doses work well for severe diarrhea from things like vagotomy, dumping syndrome, short-bowel syndrome, AIDS-related diarrhea. Conversely, low doses can stimulate small bowel motility in bacterial overgrowth or pseudo-obstruction. Very versatile. It also inhibits pancreatic secretion, useful for pancreatic fistulas, and it has a role in pituitary tumors like acromegaly, plus sometimes used in GI bleeding.
What about adverse effects? Seems like it does a lot.
It does, and there's a spectrum of adverse effects professionals need to know. Impaired pancreatic secretion can cause steatorrhea, fatty stools, potentially leading to fat-soluble vitamin deficiency. Changes in GI motility cause common GI stuff: nausea, abdominal pain, gas, diarrhea. Long-term use can cause sludge or gallstones in over half of patients because it inhibits gallbladder contraction and alters fat absorption. Rarely leads to acute cholecystitis, though. Because it messes with insulin, glucagon, growth hormone balance, you can get hyperglycemia, or, less often, mild hypoglycemia. Prolonged treatment might cause hypothyroidism, and it can cause bradycardia. Given its broad effects, careful monitoring is essential.
Okay, now we tackle another huge area of GI disease, one that really impacts patients' lives: inflammatory bowel disease, IBD. This umbrella term covers 2 distinct chronic disorders: ulcerative colitis and Crohn's disease, and their exact cause, still largely unknown, which makes treatment pretty complex.
Right. Because we don't know the exact cause, treatment often involves drugs from different classes with varied but generally non-specific anti-inflammatory actions. The choice depends heavily on how severe the disease is, how the patient responded before, and the drug's potential toxicity. Demands a really nuanced individual approach. And remember our case study from the beginning, that 21-year-old woman with Crohn's in her terminal ileum and colon. Her initial treatment with mesalamine and buccinide and then relapsing perfectly illustrates the dynamic nature of IBD, often needing a step up in therapy.
Let's start with aminosalicylates, or 5-ASA, used for decades. And a key insight is that 5-ASA is thought to work topically right in the diseased parts of the gut lining, not systemically. Raw 5-ASA gets absorbed too quickly from the small intestine, so you need special formulations to deliver it down to the distal small bowel or colon where the inflammation often is, like a targeted delivery system.
It's exactly. Two main types of formulations for this. First, azo compounds like sulfasalazine, balsalazide, ulsalazine. They have 5-ASA bound by an azo bond to something else. This structure stops it being absorbed much in the small intestine. Then, down in the terminal ileum and colon, gut bacteria have an enzyme that cleaves that azo bond, releasing the active 5-ASA right where you need it, achieving high local concentrations. Sulfasalazine has 5-ASA bound to sulfapyridine, balsalazide to 4-iminobenzoyl-balalanine. Ulsalazine is two 5-ASA molecules linked together.
And the second type, mesalamine compounds.
Right, mesalamine compounds. These package 5-ASA itself in different ways for targeted delivery. Pentasa has timed-release microgranules releasing 5-ASA throughout the small intestine. Acetylcholine and prezo use a pH-sensitive coating that dissolves around pH 6 to 7, typically distal ileum, proximal colon. Lialda also uses a pH-dependent resin around a multi-matrix core, giving slow release throughout the colon. And for localized disease, you can deliver 5-ASA directly to the rectum and sigmoid via enemas, Rawasa, or suppositories, Kenesa. Highly localized treatment. These different formulations are key to tailoring treatment to where the inflammation actually is. Pharmacokinetics. Unformulated 5-ASA gets absorbed readily from the small intestine, but very poorly from the colon. However, about 20–30% of 5-ASA from the current oral mesalamine formulations does get absorbed systemically in the small intestine. That absorbed bit gets N-acetylated in the gut wall and liver to an inactive form that is excreted by the kidneys. For the acid compounds, maybe 10% of sulfasalazine and less than 1% of balsalazide get absorbed intact. After cleavage, most of the sulfapyridine carrier from sulfasalazine gets absorbed from the colon, metabolized by the liver, excreted by kidneys. But with balsalazide, most of its karyopeptide just comes out in the feces.
And the mechanism of action. How does 5-ASA actually reduce inflammation?
Still a bit uncertain, honestly. It's thought to work mostly topically in the inflamed gut. Unlike regular aspirin NSAIDs, which block prostaglandin synthesis systemically, aminosalicylates have variable effects there. The belief is 5-ASA modulates inflammatory mediators from both cyclooxygenase and lipoxygenase pathways. Other ideas. Inhibiting NFP activity, that's a key transcription factor for pro-inflammatory cytokines. Inhibiting functions of immune cells like natural killer cells, lymphocytes, macrophages, maybe scavenging reactive oxygen metabolites. Likely a combination of these things happening right at the site of inflammation.
So clinical uses. First line for ulcerative colitis.
Yes, first line for mild to moderate active ulcerative colitis. Good for inducing and maintaining remission. Their efficacy in Crohn's is technically unproven in many big trials, but lots of clinicians use them first line for mild to moderate Crohn's involving the colon or distal ileum, just like our case study. Shows how practice can sometimes run ahead of definitive proof. Effectiveness really depends on getting high drug concentration right where the disease is. So rectal forms are best for proctitis proctosigmoiditis. Azo compounds and mesalamine formulations work for colitis extending further up. And for small bowel Crohn's, those mesalamine compounds that release 5-ASA there have a theoretical edge.
What about adverse effects? Sulfasalazine seems to be the problematic one.
Definitely. Sulfasalazine has a high rate of adverse effects. Up to 40% can't tolerate it. Mostly due to the sulfapyridine part, not the 5-ASA. People who are slow acetylators of sulfapyridine get more frequent, more severe effects. Common dose-related issues, nausea, GI upset, headaches, joint muscle aches, bone marrow suppression, feeling unwell. Hypersensitivity reactions can happen, fever, severe skin reactions, pancreatitis, pneumonitis, anemia, pericarditis, hepatitis. Also linked to reversible oligospermia in men. And it impairs folate absorption, so folic acid supplements 1 mg are highly recommended.
But the other 5-ASA formulations are generally better tolerated.
Much better. Generally well-tolerated adverse events, similar to placebo in trials. Much preferred option. Ulsalazine, though, can cause a secretory diarrhea at about 10%. Important not to mistake that for an IBD flare. Rare hypersensitivity reactions can happen with all aminosalicylates, but way less common than sulfasalazine. Some subtle signs of kidney tubular damage have been seen with high-dose mesalamine, and rare cases of interstitial nephritis reported possibly due to higher systemic 5-ASA levels. And rarely, any aminosalicylate can actually worsen colitis. Might be mistaken for refractory disease, leading to wrong treatment changes. Okay, glucocorticoids, powerful anti-inflammatories. GI prednisone and prednisolone are the common oral ones. Intermediate duration allows once daily dosing. Hydrocortisone enemas, foams, suppositories are used to directly maximize local effect in the colon. minimize systemic absorption, though even rectally, 15–30% can still get absorbed systemically.
And butzenite is designed to limit those systemic effects.
It's exactly. Butzenite is a potent synthetic analog of prednisolone, high affinity for the receptor. But it undergoes rapid first-pass metabolism in the liver, mainly by CYP3A4. Result: low oral bioavailability, maybe 10%. Most of it gets inactivated before causing widespread side effects. 2 pH-controlled delayed-release oral formulations target release to the distal ileum and colon where it's absorbed. Further targets the action.
How do glucocorticoids work broadly?
They inhibit production of a whole range of inflammatory cytokines, TNF-A, IL-1, and chemokines IL-8. Reduce inflammatory cell adhesion molecules, stops immune cells getting into tissues, inhibit gene transcription of key inflammatory mediators like nitric oxide synthase, phospholipase A2, COX2, and NFE. It's a broad-spectrum suppression, like a powerful fire extinguisher on widespread inflammation.
Clinical uses, mainly for flares.
Yes, commonly used for moderate to severe active IBD, especially during acute flares. Often start with oral prednisolone 40–60 mg a day. Higher doses aren't better, just more side effects. Once they respond, usually 1–2 winks, taper the dose carefully to minimize systemic effects. Severe illness, use IV for rapid effect. Rectal forms preferred for rectal sigmoid disease due to lower systemic absorption. That controlled release oral butzenite, 9 mg a day, is used for mild to moderate Crohn's, ileum proximal colon, and UC. Slightly less effective than prednisolone for remission, but significantly fewer systemic side effects.
But not for long-term maintenance.
Crucially, no. Corticosteroids are not useful for maintaining remission. They're for acute flares, bringing inflammation down fast. Need other meds like aminosalicylates or immunosuppressants for long-term control? This links right back to our case study. Butzenite worked initially, but she relapsed. Needed a step up for long-term control. Shows a limitation of steroids long-term.
Adverse effects. Butzenite interaction risk.
Yes. Oral controlled release butzenite is heavily metabolized by CYP3A4. So potent CYP3 horse inhibitors, certain antifungals, grapefruit juice can significantly boost butzenite levels, increasing systemic side effects even though it's designed for low systemic exposure. General glucocorticoid side effects are broad and substantial. Bone density loss, high blood sugar, increased infection risk, mood changes, weight gain. Use, especially long-term, needs very careful management. Okay, next. Purine analogs, specifically azathioprine and the 6-mercaptopurine, or 6-MP. These are purine antimetabolites. They have significant immunosuppressive properties, working to quiet down that overactive immune system in IBD.
Pharmacokinetics, I heard there's a lag time.
Yes. Azathioprine, though, has better bioavailability, 80%, than 6-MP, 50%. Azathioprine gets rapidly converted non-enzymatically to 6-MP. Then 6-MP undergoes complex metabolism. Catabolic enzymes like xanthine oxidase and thiopurine methyltransferase make inactive stuff. Short-term half-lives, 2 hours. Those active 6-thioguanine nucleotides concentrate inside cells, giving them a prolonged half-life of days. This slow buildup leads to a median delay of 17 weeks before you see therapeutic benefit in IBD. Significant lag. Crucial consideration when starting patients won't feel better right away.
How are they used clinically? Alone or combination?
They're important for inducing and maintaining remission in both UC and Crohn's.
Yeah.
Typical doses depend on TPMT activity, but often 6-MP 1×10⁴ mg/ED or azathioprine 2×2.5 mg/ED. In current practice, most commonly used in combination with anti-TNF therapy for induction and maintenance in moderate to severe disease.
Why the combination?
Added benefits. Believed to be synergistic anti-inflammatory activity, leading to higher remission rates, also reduces clearance of the anti-TNF drug, leading to higher levels, and reduces development of antibodies against the anti-TNF drug, improving its long-term effectiveness. Also, for patients relying on steroids, purine analogs can be used alone as steroid-sparing agents, reducing or eliminating steroid need. This is exactly what the case study answer suggested as a long-term option. Start an immunomodulator like azathioprine or 6-MP to achieve long-term remission and get off steroids.
Adverse effects need lots of monitoring.
Absolutely essential. Dose-related toxicities. Nausea, vomiting, bone marrow depression, low white cells, big red cells, anemia, low platelets, liver toxicity. Routine monitoring of blood counts and liver function tests is mandatory, every few weeks initially, then periodically. Low white count or high liver enzymes usually respond to dose reduction. Severe low white count increases infection risk. Might need granulocyte stimulating factor.
What about that TPMT enzyme activity? Genetic testing.
Yes, a critical genetic point. Catabolism of 6-MP by thiopurine S-methyltransferase, TPMT, is low in about 11% of people, absent in 0.3%. This genetic variation leads to much higher active 6-thioguanine levels, much higher risk of severe bone marrow depression. So TPMT levels can and should be measured before starting therapy to guide dosing. Don't give if TPMT activity is absent. Start lower doses if intermediate activity. Crucial safety step, personalized medicine. Hypersensitivity reactions, fever, rash, pancreatitis, diarrhea, hepatitis occur in about 5%.
Long-term risks. Cancer.
Pregnancy.
Long-term use is linked to increased lymphoma risk, some related to EBV. A rare but often fatal type, hepatosplenic T-cell lymphoma, seen particularly in young men, almost always on combo therapy. Also increased risk of non-melanoma skin cancers need skin checks. They do cross the placenta, but many successful pregnancies reported. Small teratogenicity risk needs careful counseling.
Any major drug interactions, allopurinol.
Yes. Allopurinol, used for gout, markedly reduces xanthine oxidase breakdown of purine analogs, dramatically increases active 6-thioguanine levels, can cause severe leukopenia. Allopurinol or febuxostat should not be given with 6-MP or azathioprine except under very careful monitoring, usually with a drastic dose cut of the purine analog. High-risk interaction every professional must know.
Okay, now anti-tumor necrosis factor, TNF therapy. These really represent a significant advance targeting key cytokines in IBD, fundamentally change how we treat severe inflammation.
Right. IBD, especially Crohn's, involves dysregulation of T helper 1, Th1 cells, and regulatory T cells, TREGs, leads to chronic inflammation. A key driver is tumor necrosis factor, TNF, produced by immune cells, non-immune cells. TNF exists in two active forms, soluble and membrane-bound. They work by binding to TNF receptors, TNFR, on cells. This triggers release of more inflammatory cytokines, T-cell activation, fibroblast collagen production, upregulation of adhesion molecules guiding inflammatory cells into tissues. Can also trigger apoptosis of activated cells. TNF is really central to the inflammation.
And the drugs are monoclonal antibodies, 4 main ones.
Yep, 4 monoclonal antibodies to human TNF approved for IBD: infliximab, adalimumab, golimumab, and certolizumab. Structurally, infliximab, adalimumab, golimumab are IgG1 antibodies. Certolizumab is different and Fab fragment linked to polyethylene glycol. PEG lacks the FVC part. This matters for its function. Infliximab is chimeric mouse human. Others are fully humanized or mostly human effects immunogenicity. Infliximab is IVV, others subcutaneous, half-lives around 8-20 days. Less frequent dosing.
How do they work? Just block TNF.
All 4 bind soluble and membrane-bound TNF with high affinity, stopping it, binding its receptors, halting inflammation. Infliximab, adalimumab, golimumab also induce reverse signaling, antibody-mediated apoptosis, complement activation, cellular cytotoxicity of activated T cells and macrophages. Extra anti-inflammatory power. Mananemab, lacking that FC portion, doesn't do these extra things. Its action is mainly just blocking TNF binding.
Clinically, these are a big step up in therapy.
Huge step up. Often transform patients' lives. Infliximab, adalimumab, certolizumab are approved for acute and chronic moderate to severe Crohn's in patients failed by conventional therapies. This is exactly what the case study recommended. Alternatively, patients with moderate to severe Crohn's disease who have failed mesalamine may be treated immediately with both an anti-TNF agent and immunomodulators. That combo approach is now a cornerstone of aggressive IBD management.
How effective are they?
Induction therapy gives symptomatic improvement in 60%, remission in 30% of moderate to severe Crohn's patients, even those dependent on steroids or failed by 6-MP methotrexate. Median time to response, pretty quick, around 2 weeks. Very welcome for suffering patients.
Induction dosing varies.
Yes, infliximab, 5 mg/kg IV at 0 to 6 weeks. Adalimumab, 160 mg initially, maybe split doses, then 80 mg SC at 2 weeks. Certolizumab, 400 mg SC at 0 to 4 weeks. Maintenance dosing, infliximab, 5 mg SC every 8 weeks. Adalimumab, 40 mg SC every 2 weeks. Certolizumab, 400 mg SC every 4 weeks. With chronic, regular therapy, clinical response holds in over 60%, remission in 40%. But about a third eventually lose response, even with higher dose frequency, often due to developing antibodies to the drug, ATA, or other unknown reasons, shows the dynamic nature of these treatments.
What about ulcerative colitis?
Infliximab, approved for moderate to severe UC failed by mesalamine or steroids. Induction, 5-10 mg at 0 to 6 weeks, gives 70% response, 1/3 remission. Maintenance every 8 weeks gives 50% continued response. Adalimumab and golimumab, also approved for UC but seem less effective than IV infliximab. Less than 55% response, 20% remission after induction. Why the difference between SC and IV anti-TNF for UC? Uncertain. Ongoing research, but important clinical distinction.
Okay, adverse effects. These are serious concerns, right?
Very serious concerns. Demand careful consideration. Serious adverse events in up to 6%. Most important, infection. due to suppressed Th1 response, compromising the immune system, can lead to serious stuff. Bacterial sepsis, TB, invasive fungal infections, Hep B reactivation, listeriosis, other opportunistic infections. Reactivation of latent TB spreading through the body has happened.
So TB testing is mandatory.
Mandatory. All patients need TB testing, skin tests, or interferon gamma assay before starting anti-TNF. Prophylactic TB therapy needed if positive before starting anti-TNF. More common, less serious infections. URIs, sinusitis, bronchitis, pneumonia, cellulitis. Risk of serious infection is markedly higher with concomitant steroids. Highlights benefit of steroid sparing.
What about those antibodies to the antibody, ATA?
Right. ATA can develop with all four. Attenuate or eliminate response. Increase risk of infusion-injection reactions. More likely with episodic therapy than regular scheduled shots reinforces consistent dosing. Prevalence on chronic maintenance, infliximab, 10%, certolizumab, 8%, adalimumab, 3%. Less likely with concomitant immunomodulators, 6-MP methotrexate.
Yeah.
Another reason for combo therapy.
Lymphoma risk, skin cancer.
Concomitant anti-TNF and immunomodulators may increase lymphoma risk, but lymphoma risk is also increased in untreated IBD. Increased cases of that rare but fatal hepatosplenic T-cell lymphoma noted in kids, young adults, almost all on combo therapy. Also increased risk of non-melanoma skin cancers. Sun protection is key. Infusion injection reactions, especially with IV infliximab. Acute reactions in up to 10%, more common after first infusion. Mild fever, headache, dizziness, hives, mild cardiopulmonary symptoms, prophylactic acetaminophen, diphenhydramine, steroids can reduce these. Severe reactions, low blood pressure, shortness of breath, muscle spasms, chest discomfort, need oxygen, epinephrine, steroids immediately.
Delayed reactions, autoimmunity.
A delayed serum sickness-like reaction can happen 1-2 weeks after anti-TNF in 1%. Myalgia, arthralgia, jaw tightness, fever, rash, hives, edema usually requires stopping that agent. Positive ANAs and anti-dsDNA can develop. Rarely, a lupus-like syndrome resolves after stopping drug.
There are rare but serious effects.
Severe liver reactions, acute failure, demyelinating disorders, hematologic reactions, new worsened heart failure in patients with underlying heart disease. Psoriatic skin rashes can develop, usually resolve after stopping drug. Powerful drugs need careful monitoring for these less common but serious issues. Okay, next, anti-integrin therapy. Different focus. Controlling cell migration. Integrins are adhesion molecules on leukocytes, your immune cells. They interact with selectins on blood vessel linings. This lets inflammatory cells stick and move into tissues like the bowel and CNS, driving inflammation.
Natalizumab was the first try here, targeted ADA for integrin.
Right. Humanized IgG4 antibody. Blocked several integrins, prevented leukocyte migration into the bowel, but also, critically, into the central nervous system. What's fascinating but also deeply concerning. Effective for IBD, but patients could develop progressive multifocal leukoencephalopathy, PML.
PML, that brain infection.
Yes. Rare but very serious brain infection.
No.
CNS reactivation of JC virus latent in most adults. Risk goes way up with 24 months treatment or other immunosuppressants. Because of this severe, potentially fatal risk, natalizumab is almost never used for IBD now. Maybe if someone has MS and IBD. Powerful cautionary tale.
So vedolizumab is the safer alternative, more gut-specific.
Exactly. Vedolizumab is a monoclonal antibody specifically targeting the I4-7 integrin. This one primarily blocks leukocyte interaction with gut vascular adhesion molecules. Key insight. Lymphocytes going to the brain are largely unaffected, so risk of JC, virus reactivation, and PML is thought to be extremely low. Much safer option for IBD.
How is vedolizumab used?
Second line for moderate to severe UC or Crohn's if anti-TNFs fail, cause side effects, or lose efficacy. Also considered first line in elderly patients where anti-TNF risks might be higher. More gut-specific approach. Given IV induction, then maintenance every 8 weeks. Very low incidence of serious side effects, neutralizing antibodies in 3%. Well-tolerated option.
Now a newer targeted approach, anti-IL-23 therapy, ustekinumab.
Right. Human IgG1 monoclonal antibody binds the P40 subunit of both IL-12 and IL-23 cytokines, blocks their signaling, cytokine production. Inhibits Th1 and Th17 cell responses thought to be crucial in Crohn's inflammation. More refined targeting. Used in adults with moderate to severe Crohn's, either biologic naive or failed standard therapy, steroids, immunomodulators, or anti-TNFs. Initial induction is single weight-based IV infusion, then 90 milligrams SC every 8 weeks maintenance. Generally well-tolerated, low-risk, serious adverse events. Hypersensitivity, infections, viral, bacterial, fungal, reactivation of latent infections, TB, herpes. Neutralizing antibodies 3%.
And risankizumab.
Yeah.
Even more specific.
Yes. Humanized monoclonal antibody binding the P19 subunit of IL-23. Even more targeted than ustekinumab, only blocks IL-23, not IL-12. Recently approved for moderate to severe Crohn's, can be alternative first-line biologic. 5e induction, 600 milligrams at 0, 4, 8 weeks, then SC maintenance, 360 milligrams at 12 weeks, then every 8 weeks.
Any specific adverse reaction with risankizumab?
A reported one is drug-induced liver injury. So liver enzymes and bilirubin monitored pre-treatment, during and after induction, then every 3-6 months. Raises an important question for professionals. How do we balance this powerful efficacy with specific crucial monitoring needs, ensuring safety while controlling disease?
Moving inside the cell now. Janus kinase, JAK inhibitors, interfering with signaling pathways, cafezatinib, upadacitinib.
Right, small molecule inhibitors of JK family. Cafezatinib is non-selective, JK3, JK1. Upadacitinib is selective JK1 inhibitor. They interrupt the JAK-STAT signaling pathway, influences production and differentiation of B and T lymphocytes involved in mucosal inflammation, acts right inside the immune cells.
Oral, how are they handled?
Rapidly absorbed, orally convenient. Short serum half-life, 3 hours for tofacitinib. Renal excretion and liver metabolism, mainly CYP3A4. So need to consider drug interactions with CYP3 or inhibitors inducers can alter levels significantly. Dose reduction needed for kidney or liver impairment. Tofacitinib approved for moderate to severe UC in patients failed or intolerant to anti-TNF therapy. Induction. 10 milligram orally BID by 8 weeks, then 5-10 milligram orally BID maintenance. Upadacitinib, similar use for UC.
Adverse effects. Infection risk. Shingles.
Like other immunosuppressants, increase infection risk, URIs, UTIs, serious infections, reactivation of latent infections, TB, significant risk, fourfold increased risk of herpes zoster, shingles reactivation, vaccination with inactivated recombinant zoster vaccine, Shingrix, 3-4 weeks before treatment, strongly advised if possible. May also increase total cholesterol, HDL and LDL, lipid testing recommended 8 weeks after starting. And crucially, FDA boxed warning. These JK inhibitors have increased risk of serious heart-related events, heart attack, stroke, thrombosis, pulmonary embolism, cancer, and death. Makes careful patient selection, considering cardiovascular risk and ongoing monitoring, absolutely paramount. Lastly, within IBD, sphingosine-1-phosphate, S1P receptor modulators. Ozanimod, right, S1P receptor agonist. Immunomodulatory med that alters lymphocyte migration. Effectively sequesters lymphocytes and lymph nodes, traps them there, keeps them away from sites of chronic inflammation in the gut, reduces immune cells fueling the fire. Recently approved for moderate to severe UC. Treatment starts with a 7-day titration schedule, slowly increasing dose, 0.23 milligram QD days 1-4, then 0.46 milligram QD days 5-7, then maintenance 0.92 milligram orally once daily. Slow start helps mitigate initial side effects. However, vital for safety, ozanimod is contraindicated in patients with recent MI, unstable angina, stroke, TIA, heart failure, last 6 months. Also, Mobitz type 2, second or third degree AV block, sick sinus syndrome, sinoatrial block, unless pacemaker present, severe untreated sleep apnea, patients taking an MAO inhibitor. Very specific, serious contraindications. Needs thorough screening.
Adverse events. Monitoring needed.
Infrequent but severe adverse events. Infections, bradyarrhythmia, slow heart rate, liver injury, macular edema, eye swelling. Because of these risks, screening with CBC, liver function tests, EKG typically done before starting. Ongoing monitoring, essential for safety while getting benefit.
Okay, let's look beyond the gut lining now to some highly specialized treatments, starting with pancreatic enzyme supplements, aiding digestion. The problem they address: exocrine pancreatic insufficiency, most common causes. Cystic fibrosis, chronic pancreatitis, pancreatic surgery. When enzyme secretion drops below 10% of normal fat and protein digestion tanks, leads to steatorrhea, fatty stools, azoturia, nitrogen in stool, vitamin malabsorption, weight loss. Body just can't break down and absorb nutrients properly.
The solution is pancreatic enzyme supplements. Contain amylase for starch, lipase for fat, proteases for protein, mainstay of treatment. 2 main types: pancreatin, lower concentrations, and pancrelipase, enriched, much higher lipase and protease activity. Pancreatin rarely used now. Pancrelipase enzymes get rapidly inactivated by stomach acid. So 2 main formulations, non-enteric coated, like Viacotate, must be given with acid suppression, BPI or H2 blocker, to survive the stomach. More common are enteric coated formulations, Creon, Pancrease, Zenpep, etc. Coating protects them through the stomach, don't require concomitant acid suppression, simplifies things.
Dosing must be individualized.
Highly individualized, based on age, weight, degree of insufficiency, dietary fat intake. Lipase is key. Usually start with 60,000, 90,000 USP units, 20K, 30K IU. Lipase activity per meal snack. Usually enough to reduce steatorrhea significantly. Suboptimal response. Could be poor mixing with food, slow dissolution. Try increasing dose, changing formulation, or adding acid suppression if using non-enteric coated. For feeding tubes, microspheres can be mixed with enteral feeds, generally well tolerated. But capsules must be swallowed whole, not chewed.
Enzymes can irritate the mouth, throat, or pharyngeal mucositis. Excessive doses can cause diarrhea, abdominal pain. High purine content can lead to hyperuricosuriasia, rarely renal stones. And worth noting, several cases of colonic strictures reported in CF patients on high-dose pancrelipase formulations years ago. Those specific formulations were removed. Shows ongoing safety vigilance. Hashtag 7.2, glucagon-like peptide 2, analog for short bowel syndrome, tetraglutide.
Moving on to glucagon-like peptide 2 analog for short bowel syndrome, specifically tetraglutide. The challenge here: extensive small intestine resection or disease causing short bowel syndrome, severe malabsorption of nutrients, fluids. Patients with less than 200 centimeter small intestine often depend on parenteral nutrition IV feeding to survive. Huge impact on quality of life.
KATZUNG's mechanism is pretty innovative. Tries to help the remaining gut adapt. It's a GLP-2 analog. Binds to enteric neurons, endocrine cells, stimulates release of trophic hormones like insulin-like growth factor. These promote mucosal growth, enhance fluid absorption in the remaining gut, trying to maximize its function. Trials showed 54% on tetraglutide, 0.05 mg/kg in QDSC, reduced parenteral support need by at least 1 day a week versus 23% placebo. Significant improvement for these patients. Important note, may be linked to increased risk of colorectal and small bowel neoplasia. Needs careful monitoring.
Okay, bile acid agents for gallstones and liver disease. Ursodiol or ursodeoxycholic acid.
Right. Naturally occurring bile acid. Less than 5% of human bile normally, but much higher in bears. Oral, absorbed, conjugated in liver, excreted in bile. Extensive enterohepatic recirculation cycles through liver gut. Long serum half-life, 108 hours. Long-term use makes it 30–50% of the bile acid pool. Changes bile composition significantly. Small amount unabsorbed hits colon. Bacteria can dehydroxylate it to lithocholic acid, potential liver toxicity, but usually minor.
How does it work?
2 main actions. First, decreases cholesterol content of bile by reducing liver cholesterol secretion. Makes bile less likely to form cholesterol gallstones. Second, seems to stabilize liver cell membranes, maybe by reducing toxic bile acids or inhibiting immune destruction. Particular effect on liver cells.
Clinical use: gallstones.
Used for dissolving small cholesterol gallstones, 5 to 10 millimeter non-calcified. In symptomatic patients who refuse surgery or are poor candidates, 10 milligram kilograms orally for 12–24 months can dissolve stones in up to 50%. Slow process. Also prevents gallstones in obese patients during rapid weight loss, high-risk time for stones. Makes bile less prone to crystals. Also first line for early primary biliary cirrhosis, PBC, that autoimmune liver disease. As a non-toxic bile acid, it reduces liver injury by replacing more toxic ones, plus anti-inflammatory effects. At 13–15 milligram BQD, improves liver tests, slows disease progression, reduces transplant need, improves survival. But about 35% don't respond adequately alone. Need more. Side effects: pretty safe. Remarkably safe. Practically free of serious side effects. Bile salt diarrhea, uncommon. Unlike its predecessor chinodeoxycholate, Rhizodiol not linked to liver toxicity, big plus. Obeticholic acid, synthetic derivative of chinodeoxycholate, also considered non-toxic bile acid, reduces liver injury by lowering toxic endogenous bile acids. And it's a ligand for the nuclear farnesoid X receptor, FXR. Fascinating. The FXR modulates liver inflammation, fibrosis, glucosilipid metabolism, insulin sensitivity, multifaceted.
Using PBC, combination.
Approved for PBC, 5 to 10 milligram but orally, in combination with ursodiol, specifically for inadequate responders to ursodiol alone. Trials show almost 50% response with combo versus 10% ursodiol alone. Additive benefit. Notable side effect. Causes severe pruritus, itching in up to 25%, especially 10 milligram a dose. Leads to stopping in up to 10%. Can be a major quality of life issue. Also being studied for NASH, not yet approved. Finally, drugs used to treat variceal hemorrhage, life-threatening complication of portal hypertension. The danger: portal hypertension, usually from cirrhosis, caused by increased portal blood flow and increased resistance in the liver. Leads to ascites, encephalopathy, and those portosystemic collaterals, especially gastric or esophageal varices. Dilated veins that can rupture, cause massive upper GI bleed. Immediate goal: reduce portal pressures, short-term for active bleed, long-term to reduce rebleeding risk.
What agents are used? Somatostatin and octreotide?
Yes. In cirrhosis with portal hypertension, IV somatostatin, 250 ml/CGHR, or octreotide, 50 ml/CGHR, reduce portal blood flow, variceal pressures. Mechanism: poorly understood. Don't directly contract blood vessels, may be mediated by inhibiting release of glucagon, other gut peptides that alter mesenteric blood flow, thus reducing portal flow. Trial data conflicting, but these agents probably effective for initial hemostasis from bleeding esophageal varices. Usually given 3–5 days to control bleed, prevent early rebleed.
What about vasopressin and terlipressin? Vasopressin seems risky.
Vasopressin, antidiuretic hormone, is a potent arterial vasoconstrictor. Continuous effete causes splanchnic vasoconstriction, reduces gut perfusion, lowers portal pressure. Used historically for acute variceal bleed, but no longer used systemically for this due to high adverse effect profile.
Limited use now. High risks.
Very limited current use. Might still be infused directly into mesenteric arteries via catheter for localized vasospasm in bleeding from vascular ectasias or diverticulosis. Specific situations. Systemic side effects common, severe. Systemic peripheral vasoconstriction causing hypertension, myocardial ischemia infarction, mesenteric infarction. Can reduce these slightly by co-administering nitroglycerin, but doesn't eliminate risk. Other common effects, nausea, cramps, diarrhea, gut hyperactivity, plus antidiuretic effects. Water retention, hyponatremia, fluid overload, pulmonary edema, powerful drug, many systemic issues. Terlipressin is a vasopressin analog. Similar efficacy, fewer adverse effects. Preferred where available. Widely used elsewhere, but not approved in the USA yet.
Lastly, beta receptor blocking drugs for prevention.
Right. Non-selective beta blockers like propranolol, nadolol reduce portal pressure by decreasing portal inflow. Two mechanisms. One, decreased cardiac output by Beta blockade. Two, splanchnic vasoconstriction, Beta blockade, due to unopposed systemic catecholamines on adequate receptors.
Non-selective are better than selective.
Yes, non-selective beta blockers. More effective than selective BRO1 blockers for reducing portal pressure. Key clinical point. In cirrhosis patients with varices who haven't bled, they cut bleeding incidence, 15%, 25% controls. Meaningful reduction. For those with a history of variceal bleed, 80% recur within 2 years. Non-selective beta blockers significantly cut rebleeding rates. Mortality reduction unproven, a cornerstone of long-term prevention for this deadly complication. Hashtag outro.
Wow. Okay. We've just taken a whirlwind yet incredibly deep tour through the complex and vital world of gastrointestinal pharmacology. Seriously, from balancing stomach acid with antacids and PPIs to reinforcing the gut's own defenses, influencing the gut's nervous system with prokinetics and laxatives, and finally, tackling chronic inflammatory diseases and those acute life-threatening conditions.
Yeah, what we've really seen is how precisely targeted yet often broadly impactful these medications can be. Understanding the nuances, the mechanisms, the pharmacokinetics, how the body handles them, the side effects, the crucial drug interactions, as we've just done, that truly is the mark of an elite professional. You now have a comprehensive framework to not just grasp the details, but to ask deeper questions about what's next. Really gives you mastery of this field.
You wanted to master this information, and by exploring every layer, every specific drug, its role. You've gained an incredible shortcut to that level of understanding, seeing those connections, the clinical significance that really matters.
So what does this all mean for the future of GI pharmacology? If we connect this to the bigger picture, with the rise of these highly specific biologic therapies, the promise of precision medicine, it really raises an important question. Will we eventually move beyond these often broad-spectrum approaches to entirely personalized gut health solutions, tailored down to the individual's unique microbiome, their genetic profile, and, what exciting new challenges, opportunities will that present for medicine as we try to fine-tune treatments to a level we haven't seen before?
That's our deep dive for today. Keep that curiosity burning, and we'll catch you next time.